Today we are going to learn how to perform the less invasive surfactant administration procedure. LISA or less invasive surfactant administration is a technique of delivering surfactant with the help of a thin catheter in a spontaneously breathing preterm infant on non-invasive respiratory support. Studies have shown that surfactant administered by the LISA technique results in a significant reduction in the need for mechanical ventilation and the composite outcome of death or bronchopulmonary dysplasia at 36 weeks. Equipment needed for the procedure are a videolaryngoscope with appropriate size blade, LISA cath, which is a catheter specifically designed for the procedure, 5 ml or 10 ml Luolox syringe, IV connector, needle to draw up the surfactant saturation probes, nasal prongs or face mask for the delivery of PEEP to the infant, a nasogastric tube, and an oral syringe. Most of the equipment can be found in the LISA pack. Keep surfactant ready in the dose of 200 mg per kg to the nearest vial drawn into a 5 ml or a 10 ml IV syringe. And now attach this to a TP cannula connector. Emergency equipment such as neopuff, appropriate size laryngoscope blade, endotracheal tubes, and suction should be readily available if needed. At least 3 people are needed for the LISA procedure to be successful. Switch the videolaryngoscope monitor on by pressing the button on the front of the monitor. Unscrew the cap of the laryngoscope connector and plug it in the monitor, making sure to align the red dots on the connector port and the monitor port. Attach the appropriate size laryngoscope blade to the handle. Remember, these blades are not disposable and will need cleaning after the procedure is done. The light on the handle will turn on and a live video will be projected on the screen as demonstrated. The infant should have continuous monitoring of the heart rate and oxygen saturations. The infant should be stable and spontaneously breathing in order to qualify for the LISA procedure. Now the infant should be swaddled for comfort and positioned in an appropriate manner, ensuring adequate warmth to maintain the infant's temperature throughout. In case of very small and premature infants, consider the use of transformer. A nasogastric or orogastric tube should be inserted to allow the stomach to be aspirated prior to and during the procedure. Maintain the infant on nasal CPAP via face mask or nasal prongs. Administer pre-medications if performing the procedure on the unit. This is not needed if performing the procedure on the delivery suite. Visualize the vocal cords with the help of a videolaryngoscope, with or without the nasal prongs CPAP as per operator preference during the insertion, and connect the nasal interface back once the catheter is in. Insert the LISA catheter whilst holding the catheter in the middle until the required marking, which is between 1 and 2 centimeters. Note the mark at the lips and remove laryngoscope and maintain the LISA catheter in the midline position. Continue with the ongoing PEEP delivery via face mask or nasal prongs, as this along with the spontaneous breathing effort of the infant help in the distribution of the surfactant. Second person to administer surfactant slowly over 3 to 5 minutes. This is the most crucial step of the procedure, as the surfactant administered rapidly will lead to more adverse events. Briefly stop surfactant delivery if bradycardia desaturation occurs and resume when this is resolved. If there is apnea, the infant can be stimulated, and if still not improved, may need further resuscitation as per the NLS algorithm. Remember, this is not an emergency procedure. Stop if having difficulties and consider alternatives. Aspirate the nasogastric tube continuously during the procedure Small amounts of surfactant may be aspirated in the NGT, which is acceptable, but if there is a large quantity, there is potential misplacement of the catheter. In this case, pause and have a look with the video laryngoscope to ensure LISA catheter is in situ. Remove the LISA catheter and continue non-invasive respiratory support and nurse the infant if prone, if possible. Record the time of surfactant administration, duration over which surfactant administered, any desaturations, bradycardia, and surfactant reflux during the procedure.
Cleaning instructions for video laryngoscope after use. Step 1. Cleaning. Remove the pre-clean wipe from its sachet and unfold it in the palm of your hand. Wipe the probe to remove all visible soil. Discard the used wipe and gloves to clinical waste. Disinfect your hands and put on new gloves. Step 2A and 2B. Activating. Remove the sporicidal wipe from its sachet and unfold it in the palm of your hand. Take the activator foam bottle and apply 2 doses of foam onto the wipe. Fold the sporicidal wipe in on itself and scrunch it during 15 seconds to generate chlorine dioxide. Ensure that the wipe is completely covered in foam. Step 2. High-level disinfecting. Wipe the surface of the laryngoscope blade in one movement to cover it with foam, ensuring all areas come into contact with the wipe. You must observe a minimum contact time of 30 seconds. Step 3. Rinsing. Remove the rinse wipe from its sachet and unfold it into the palm of your hand. Wipe the blade to remove excess foam. Discard the wipe to clinical waste. Step 4. Traceability. Remove the stickers from the back of the blue wipes. Insert sticker into the Tristel Quality Audit Trail record book as demonstrated.